Good morning. This is Himanshu Patel. I'm privileged to present at the 2020 GenTAC Aortic Summit on the topic of endograft therapy, when and how. These are my disclosures. There is no disease more conducive to clinical humility than aneurysm of the aorta, said the noted physician Sir William Osler over 100 years ago. Nowhere is this more prominent than for aneurysms of the arch and of the descending aorta. Patients presenting with aneurysms in these locations or pathology in these locations often have significant associated comorbidities and require high-risk surgery. For many years, the only options that were available were those of open surgical repair to treat pathology such as this. These patients often had associated severe obstructive lung disease, coronary artery disease, peripheral arterial disease, all of which made open surgical repair significantly high risk. Over 25 years ago, an option of treating patients with thoracic endografts became available. This came into widespread use in the mid-2000s as a result of multiple Food and Drug Administration clinical trials. The pathology used to treat pathology treated in these clinical trials often included pathology such as this. And this is what I term the good old days. The thoracic endografts that were originally approved by the FDA are seen here. Each of these three devices had their unique characteristics, but as one can tell, they are used to treat relatively straight portions of the aorta and in essence became extensions of what was initially used in the abdomen. So infrarenal thoracic or infrarenal aortic endografts. As a consequence of this introduction of this minimally invasive therapy, the morbidity and mortality for treatment of aneurysms shown previously markedly decreased. Patients were discharged from the hospital quite quickly with marked reduction in morbidity and mortality. This led to a significant growth in the volume of thoracic aortic procedures in the United States, and as this slide suggests, the consequence of introduction of TEVAR led to an increase in the volume of aortic procedures as is shown in red, and this was primarily a consequence of the growth of TEVAR as shown in green. Despite the reduction in early morbidity and mortality, there remained a persistent risk of aneurysm rupture or mortality. And this had to do in large part to the risk for endoleak, such as shown here. There are various types of endoleaks, including those related to failure of attachment zones at the edges of the endografts, branch vessel retrograde flow, or in most cases of modular components, the risk of junctional endoleaks or flow between components. The attachment failures really had a basis in open surgery. As this work in 1997 from the University of Rochester suggested, the biology continues to progress in attachment zones. So in this group of patients who had open infrarenal aortic repair, Dr. Illig and colleagues found that 1/3 of patients had dilation of the proximal aortic cuff over time. And that if the initial proximal aortic cuff was greater than 28 millimeters in diameter, the likelihood of neck degeneration was much higher, again suggesting that the biology of the aorta wins. In fact, at the University of Michigan, one of the first patients patients treated in the thoracic endograft, in the first thoracic endograft trial, made it through the 5 years without any complications, with successful exclusion of her descending thoracic aortic aneurysm. In year 8, however, her proximal landing zone dilated, and she developed an endoleak, reperfusion of the aneurysm sac, and required redo TEVAR, highlighting the concept that these patients need to be followed over time. Well, there are many differences between the original endografts used for infrarenal pathology and the requirements for endografts in the thoracic aorta. The first and most important difference is that thoracic aortic pathology is much more varied than that frequently seen in infrarenal aneurysm disease. In the latter, the predominant pathology is degenerative, whereas in the thoracic aorta, the pathology is much more varied, as is seen in 4 such examples of fusiform, saccular, traumatic, and dissection-associated aortic pathology. In addition, there are significant differences in hemodynamic considerations for engineers who design these devices in the thoracic aorta. There is the curvature of the arch, which is an area or a segment of the aorta that is more curved than generally any other part of the entire aorta. And obviously critical branch vessels that need to be accounted for as we expand our when and how of endograft therapy. Well, as thoracic endograft designs have evolved, what has happened as a consequence in the last 15 years since the approval of the first thoracic endograft is a remarkable shift in the technology of the endovascular devices. Here's an example of the newest therapy for acute type A aortic dissection, which now has expanded our when and how. This was a 90-year-old female who presented with a medical history of hypertension and had symptoms of acute chest and back pain, who was relatively functional, and as this CT scan clearly demonstrates, presented with an acute type A aortic dissection. Well, what would be the options of therapy for this particular patient? One would be medical therapy, which is associated, as we all know, with a dismal prognosis. Second is open surgery, which for a 90-year-old, despite her being functional, likely could be associated with morbidity. Third is the newer option of endovascular therapy, but understanding that the device design may need to be different. And then the fourth consideration in this segment of the aorta, which is not present in the traditional segments that are treated by thoracic endovascular aortic repair, is that this particular patient has associated severe aortic valve insufficiency as a result of prolapse of the dissection flap in the root. Well, this patient was consented for a clinical trial device that is shown here. We approached this patient through a transfemoral manner in order to deliver the device into the ascending aorta from the femoral arteries. We required a procedure known as a pre-rupture technique of the iliac arteries, where the stent grafts are placed, where small stent grafts are placed in the iliac vessels, and the iliac vessels are intentionally ruptured to accommodate the device diameters. It requires a wire in the left ventricle, and partial deployment is, as is shown here, in a 2-stage manner. And when fully deployed, this particular therapy for this particular circumstance resolved the aortic valve insufficiency and excluded the ascending aortic tear. As the echocardiogram shows, the aortic valve insufficiency went from severe to mild as a consequence of endovascular resuspension of the aortic valve leaflets. To deal with critical branch vessels and the curvature of the aorta, there have been many devices that have been developed, all in various stages of clinical trials in the United States and overseas. Well, with any problem that is solved, or focused on, one can be sure that we will identify additional problems that need attention. This is a study from our group that describes the consequences of thoracic endovascular aortic repair. In this study, we took 8 patients with aneurysm disease who had CT scans pre and 1 year post TEVAR, echocardiograms pre and 1 year post TEVAR, and subjected them to patient-specific computational fluid dynamic analysis using fine element meshes and generating pre and post TEVAR elastance functions. What is computational fluid dynamics? Well, essentially what this does is it solves or attempts to solve the Navier-Stokes equations, which model weather, ocean currents, and in our scenario, blood flow. This has been designated one of the 7 millennium problems with a $1 million prize for any in the audience who can solve this. Well, why do we care about CFD? Because a healthy aorta is not just a tube. It facilitates ventricular ejection and efficient perfusion of end organs. We don't generally make a detailed analysis of blood flow in clinical practice, and we generally perform therapy for disease we see without fully understanding its implications. In essence, we do not do what our physicist colleagues have done for many years, and that is there are no Gedenken experiments in medicine. Well, how does a surgeon do it? A surgeon finds a friend who's got a very expensive toy. In this case, a supercomputer. We use data and patient-specific computational models, including an analysis of geometry from CT scans, flow using echo-derived cardiac output, and blood pressures, all of which have their limitations. And what we found in this particular study is that there was a significant increase in LV mass, both by echocardiograms and by CT scans following endovascular aortic repair. And this was likely a result of, or a consequence of the increase in left ventricular stroke volume, as shown by generation of pre and post TEVAR elastance functions. This Windkessel effect essentially unloads the heart in systole by reducing impedance and maintains forward flow in diastole. And the stiff aorta, or in this case, an endograft or an open graft, resulted in an increased afterload by elimination of this so-called Windkessel function. The consequences of this could be suggested from studies that evaluated the consequences of isolated systolic hypertension that occurs as we age and our aortas become stiffer. And that is, their incidence of heart failure increases over time. So in summary, endograft therapy, while now decades old, remains in evolution. Device development continues to refine when and how. And as is usual, newer problems arise when we solve older problems. I would like to thank Dr. Eagle and colleagues for the privilege of presenting at the GenTAC 2020 Symposium. Thank you so much.